Okay, so good evening to one and all. So we are back with another session, and this one is called Shadowboxing. So we've done several of these sessions in the past. So I will just briefly review what this session is all about. What happens is that I will present a particular case in several aliquots, and at the end of each aliquot, we're going to discuss about how we would go forward and your next step would be in evaluating or treating the particular patient. So if you are watching this later on in a video somewhere, I would recommend that you pause the video after each aliquot so that you can fully gain the learning experience from this video and session. So you'll start with the first aliquot. So what you have is a 29-year-old young lady, and she was admitted in another hospital, and she had a cesarean section done. The indication was some fetal distress, and after that, she was admitted there for a few days. By around post-op day two, she started developing high-grade fever, jaundice, decreased urine output. She had a session of hemodialysis done out there also, apparently. Now she's being referred to your center on post-op day 5 in view of refractory shock. So this is not uncommon. So I would like to ask each of those who have come online today to just tell how you would initially approach this particular case. Yeah, this patient. This is the initial history that you are given. So you can just unmute itself and start, or otherwise I can just ask one of you to start. Okay, Mayuri, how would you initially approach this case? What is the first thing that you don't want to know? What is the first thing that you'd like to do? Very simple. Yeah, I'm not sure. Hi, yes, Mary.
So ultrasound to look for retained productive conception,
Okay, you might think about that eventually, but before that, in the ED, what would you initially be interested in knowing?
blood pressure,
Yeah, so you'll do primary survey, no? So, okay, here is the primary survey. Airway is patent, patient is tachypneic, 34 breaths per minute. Saturation is about 100% on oxygen by face mask. Pulse rate is 145. BP is 48 by 22. Patient GCS is okay, but she's a little bit drowsy, E3, V4, M6. RBS is normal. Patient is febrile to touch. So, what did you immediately like to do here? Well, as somebody else, Dr. Akshay. So, what did you immediately like to do next? Okay. Anybody else wants to take a swing at what they'd like to do next? Okay, I'll give you some more information anyway. See. So on further examination, patient is icteric. General examination otherwise is significant for some lower abdominal tenderness, mostly around where not the scar actually. I'm sorry. So the basically around the surgical incision site. So patient no gross neurological deficits. Right subclavian central line is already in situ, and Foley's catheter is already inserted there, and apparently there's some 100 ml of urine in it. That's how much the patient has been able to produce in the last 24 hours. Patient is conscious, drowsy, peripheries are warm, peripheral pulses are felt. Refill time is prolonged. Urine output, obviously, as mentioned, is decreased. So, okay, so ultrasound to look for RPOC, that is fine. But before that, you will try to stabilize the patient with IV fluids. And initial focus, you do a quick focus here. IVC is like borderline because that is not surprising because patient has already been admitted outside somewhere. So obviously, patient must have received some kind of IV fluids or some kind of blood products. We are not really sure about exactly how much the patient has received. So we we don't have much to go with there. But generally, they must have received something because it's post of day 5. Heart is grossly, there's nothing very alarming here, but EF is not exactly normal, somewhat reduced around 35, 45, 40%. Lungs are fine, nothing grossly abnormal there, except some occasional B lanes in zone 3. And if you're looking at the blood gas, patient is having a metabolic acidosis. She is compensating. Anion gap is around 15. Lactate is a little bit high. And patient was shifted here on dopamine infusion. Okay. So, and let's just assume the RPOC ultrasound was done, it was negative. So, the point here is not really to figure out why the patient is in shock. Maybe it's some kind of, most likely, some kind of post of infection, maybe. Or another thing, it could be that patient was given some blood products and had some acute hemolytic transfusion reaction. That's another possibility, other than retained products of consumptions as well. So those are the main thing. But patient is basically from what we have been given so far in terms of information. What kind of shock do you think the patient is having? Cardiogenic, hypovolemic, septic, hemorrhagic. What kind of shock does this basically seem like? Yeah, this basically seems like sepsis. So the next question is, do you want to change the vasopressor being used here to something else, or do you just continue with what is given? So, do you continue dopamine, or do you consider giving switching over to something else? Now, this scenario is not uncommon, but it is different from other cases because patient has already been treated somewhere else. So, again, coming to a new center, again, bolusing with fluids, perhaps not going to be very useful. So you can try. So patient is kind of borderline. Borderline. It's not exactly a kissing IVC or anything. So you can try some fluids. Probably not harmful if you give some 500,000 ml of ringer lactate here. So you can try that, and it was done, but didn't really produce much of a difference in this particular patient. So this is based on a real patient, but this is modified because I don't want to reveal patient identities, and also this is not exactly the real case, but something similar to some case that we had recently. So the question is, do you want to change the inotrope? And somebody has already written that you'd like to change it to not adrenaline. So why is that? Why do you want to change it from dopamine to something else? Yes, so start on noradrenaline while tapering of dopamine. That is general. That is a pretty reasonable approach here. So it is not a good idea to actually continue that infusion because one thing, we don't know who made it. We don't know if it was made appropriately. Most of the time, we receive patients on infusion that use different concentrations than the usual things that our nursing staff are used to. So there isn't a lot of sense in actually continuing those infusions. So it is better to actually change the infusion. Obviously, dopamine is not the infusion of choice in a patient with septic shock. It is going to be noradrenaline. But patient is already on it, and patient is already BP is basically in the toilet here. So it's probably not a good idea to taper it off completely and then start noradrenaline. Probably a better idea to actually try to keep it going, start not adrenaline, and just slowly wean it off once we have NORAD on board. So that is a much more sensible approach. Another thing that I would that you'll have to decide is whether you want to change the central venous line or not. Patient is already having a central venous access here, right subclavian. So one thing that you have to look for when you have subclavian line is whether the patient is having pneumothorax or not. So that is why the focus here was important. So again, so like lung starting was present, so unlikely that the patient is having significant pneumothorax at present, leading to shock. But the question is whether do you want to change the center line to something else because patient is septic, or you just want to continue to use that line. We don't know when exactly which day it was inserted. We just on examination we note that a central line has been inserted. You have no idea how many days it has been since it was inserted. So do you continue with that this center line or continue using the center line, or you change it out for something else? So what do you think? Mayuri, what do you want to do? You want to continue using this line, or you want to change the line?
So you can send blood culture from that site input for the uh, result.
Yeah, that is something we can do. Another thing we can do is you can see if there is backflow and forward flow in the all three ports and all to make sure that it's actually functional. So if it is actually functional, it won't be a good idea, especially in a patient who is this sick, to actually start going for a new line. Eventually, the patient will need a new line probably because we have no idea about under what kind of sterile precaution this particular line was actually inserted in. So eventually, we will have to change the line considering all of those factors, but that is not an immediately necessary thing. Not in this a patient who is this sick. So immediately in a patient this sick, as long as the line appears to be working, you would not want to actually remove the line. So that is one thing. So next thing is a patient is on having a BPF 48/22. So, but you are having peripheral pulses are palpable, and you are putting the patient on a non-invasive cuff. In between is coming like 170. Peripheral pulses, peripheries are warm. Peripheral pulses are palpable, but in between it's again going back to 70/30, 50/30, etc. Beach may it's again coming up to 90/60. So do you think all of these readings, the 48/22, is false readings, and whether we should just ignore that and you just ignore the 160 readings that come in between? So if you don't feel like speaking, you can just type it out also. Do, do you think this is a false reading because peripheries are warm? Okay, let somebody else start the question. Do you want to answer that? Do you think this is a false reading? And do you think this is possibly true?
I think it's false, sir, although I'm not very sure.
Yeah, so some other people have replied here. So peripheries can be warm due to septic shock. Patient is febrile. Patient is having fever. So that can be one of the reasons why patient's peripheries are warm. So another thing is patients who are having severe sepsis, they can have intermittent catecholamine surges that can actually momentarily increase the BP somewhat. So it is not uncommon for you to see BP readings that fluctuate between 100, then back down to your 60-30 range. So that can happen in sepsis, and that is also not a good thing. So that it is you should not assume that okay, it's a good thing that patients BP increase a little bit in between. So I just continue with what I'm doing, because each time that category, I mean, surge happens, so that reserve reduces by more and more. So and the patient gets closer and closer to completely crashing and going into cardiac arrest. So this patient will need resuscitation. And another thing is, this is another important point, that if you have invasive BP monitoring, this is the perfect case where that becomes useful, because you have very good monitoring of what is actually happening to the patient's hemodynamics. So when you have BP that is very very low or very very high, the non-invasive cuff becomes very unreliable. And I've seen many cases where some patient who was actually having severe sepsis, lactate 15, 20, etc., and patient had a false BP reading of 180, 100 or something, and unfortunately somebody decided to give labetalol for that patient or something similar. So you have to be very, very, very careful. That is why in any patient whom you are suspecting of having shock, you evaluate clinically for these things: the patient sensorium, whether how the patient's periphery are, how is the capillary refill time, how is the urine output. So these are the things that we use to assess end organ perfusion. So if these things are affected, that means that patient is definitely in shock, and the patient might benefit from some IV fluids, or more importantly some vasopressors. So that is one thing. Again, if you can get a arterial line in place very very quickly, then that would be something very useful in this kind of patient. Even though I would not put it as a priority over other things, but it is something that you should consider even in the emergency department, because it can make a difference to patients. So we already discussed this. So this is how we approach. So initially we came here with this history, assess the primary survey, a quick secondary survey, assess for the features of end organ perfusion that we can assess clinically, did a quick focus, and did a blood gas. And these are the basic things that you would do for any kind of very sick patient. So this is what was done. Patient was basically started on some IV fluids. We were started on the vasopressors, noradrenaline, and it was titrated very quickly up. Then patient was also started on vasopressin. Cultures were sent, and broad spectrum antibiotics were started. So after that, next step is we was discussed with the ICU team, and they decided that the patient is going to be shifted to the ICU. So the ICU is a bit far away in another building. So they asked you to intubate this patient before shifting, because patient's hemodynamics was still unstable. So patient BP was fluctuating somewhere around 80, 50, 90, 60, that kind of range. And sensorium was a little bit borderline. So they said it's a better idea to just intubate before you shift the patient. So the question I would ask is, would you actually intubate this patient for this reason, or would you say no? I'll just take my chances and hope that patient does not crash while actually shifting to the ICU. So anyone wants to volunteer to answer this question? Intubate, yes or no? Okay, somebody says intubate. Anybody else has any opinion? Anybody who says that they don't want to intubate the patient before shifting? Yeah. So basically, if you're going to shift the patient here, it's a better idea to secure the airway before shifting, but with the caveat that you have to be careful about post intubation. Patient going into even worsening hypotension and going into cardiac arrest. So that is the big issue here when you're trying to intubate any patient with severe septic shock who is having acidosis, who is breathing fast, who is compensating, but patient is not actually having that good of a sensorium to keep she's already getting a bit tired, already getting a little bit drowsy, so, and patient's BP is like really low. So you're going to be taking a huge risk if you're going to shift this patient without securing the airway. And she's has having a problem, probably some intra-abdominal sort of sepsis, and it's going to be not something that you can rapidly fix. So it's going to be take a long time for this patient to actually start improving. So it's not something like hemorrhagic shock where okay, you can pump in a lot of blood products and patient will improve, then you can maybe even avoid intubation. In this kind of patient, it is possible that eventually patient is going to need intubation. So and eventually, if the patient does need intubation, it would probably be better of securing the airway before it becomes a kind of a peri-arrest scenario, because once a patient completely loses consciousness, and then the patient pH becomes even worse, then it becomes a very difficult scenario to actually salvage. So there is no real fixed cutoff on when you should do this, but considering this particular scenario, when the patient's uh, next course of action has already been decided, it's a better idea to actually intubate rather than shifting a patient with this kind very labile blood pressure. So you are planning for intubation, but then you notice that the patient's heart rate on the monitor has increased to around 200, which is again, even in sepsis, that is not really normal. And the patient's ECG is done showing atrial fibrillation with a rapid ventricular rate. So you do another primary survey. You reassess the patient. Again, patient is tachypneic. Now the difference here is the patient's heart rate is very sky high, over 200, irregular. BP is around 78 by 33 on vasopressors. So the question here is, what would you do next? And we are assuming here that the initial rhythm was actually sinus tachycardia, and now patient has gone into atrial fibrillation basically in front of you. So the options I'll give you is you do DC cardioversion, synchronized cardioversion. Great. But for that, you'll have to, this is a conscious patient, so you'll have to sedate. Do you want to sedate this patient? Second thing is, do you want to secure the airway, then do cardioversion? Or do you want to try some rate control medication first and then consider intubation? So this was a real scenario. So these were basically the things that the providers in this particular case had to consider. So I'll again ask Mayuri, what do you think? How would you approach this scenario now?
So
Pa-
first rate control and then intubation.
Okay, how do you rate control?
As the patient is altered and blood pressure is also low, so synchronized cardioversion.
So you want to sedate the patient.
Yes, sir. But,
B, BP is 70/30.
mm,
So again, in this particular case, patient was other even though patient has gone into AF with FER, the periphery was still warm, patient was still conscious. So it has not become the scenario hadn't changed that much from what how it was initially. That is one thing. If you are sedating this, so one thing is that doing DC cardiovascular without sedation, that is not ethical in a conscious patient. So I would not recommend that anybody actually try that, and so that is not a proper option here. Sedation with DC cardioversion, again, if you sedation in this kind of patient without a secured airway, it is going to be very dicey. A lot of things can go wrong. Patient is compensating for acidosis. You are sedating the patient. Acidosis can get worse, and patient is already having a very bad blood pressure. So the next step here is actually not any of these things. Next step here is actually to try to get a BP up more, because whatever you want to do, whether it is sedation and cardioversion, or whether it be intubate first, then cardiovert later. So however you want to play it, yeah, you cannot do either of those things with this blood pressure. That is not possible. So the question here is how do you actually, patient is already on two inotropes. So how do you actually plan to get the BP up so that you can actually do something about it? So anybody can give some ideas about this. How can we actually increase the blood pressure so that we can actually do some of the procedures that I mentioned? Anybody having any idea what medication do we usually give to combat peri-intubation hypotension? Push dose pressors. Good. Push dose pressors. What is the problem with push dose pressure here? Do you think adrenaline is a good idea with a patient with a heart rate of 200? Oh, very nice. Very nice. Somebody has mentioned the correct answer. Phenylephrine. This is a great scenario for the use of push dose phenylephrine, because you want to increase the heart rate, the blood pressure without increasing the heart rate, because the heart rate is already through the roof. You do not want to give something like ADR, which has a very significant chronotropic effect. That would not be a good move. This is the perfect scenario for some phenylephrine. It will pump up your blood pressure to allow you to either cardiovert or to intubate or whatever thing is right, without actually pushing the patient over into cardiac arrest. So in this particular case, what we eventually decided was that uh, whether it was right or not, you can debate there, but it was decided to it will be safer to do whatever you want to do after securing the airway here, because too many things were wrong here to actually play around without securing the airway. Push dose phenylephrine was given, pre-oxygenated with an IV in, medication. This is given for intubation for ketamine and rocuronium. Then post intubation, we cranked up the ventilator settings to make sure that there is patient was actually going to compensate for metabolic acidosis, because if you can promise, so one thing that if you do not adjust your ventilator settings to provide adequate minute ventilation, this patient will go into post intubation cardiac arrest. That is without a doubt going to happen. So you have to adjust the ventilator settings so that the patient is not going to crash post intubation. So that was done. After intubation, cardioversion was done, r- late converted to sinus tachycardia. Post intubation, patient's vitals improved somewhat. Heart rate of 138, which is sinus, BP of around 170, and SpO2 of around 100%. And after that, the patient was shifted to ICU. So this was basically a very common scenario in emergency department, so where we provide the acute care for the patient and try to provide the safest possible care for the patient before the patient is shifted over to the ICU. So we having said all that, now we'll just discuss a few things about vasopressor, because that is basically what this whole talk was about: how to select vasopressors and how to utilize them in various scenarios. So they are basically, they can be divided into catecholamine vasopressors and non-catecholamine vasopressors, but this is not very perfect classification, because some say that phenylephrine is not exactly a catecholamine, but anyway. So catecholamine vasopressors basically act on alpha 1, beta 1, and beta 2. Alpha 1 is basically going to cause vasoconstriction. Be, beta, we have beta 1 and beta 2. Beta 1 is what is going to increase your heart rate and contractility, and beta 2 is what actually causes your bronchodilation. So phenylephrine is pure alpha. It will increase your, basically increases peripheral vascular resistance, and it is not a very commonly used drug, but it can be useful in very specific scenarios where you are wanting to increase your uh, blood pressure, especially as a push dose vasopressor. When you don't want to actually increase the heart rate, is a very good option. Noradrenaline is basically the drug of choice for most types of shock, especially if, of shock of unknown origin. So it has predominantly alpha action. So basically, it's predominantly alpha. I think this is something that I also didn't know, because I also thought it was predominantly beta, but no. Early in my career, I used to think it was predominantly beta, but no, it is predominantly alpha rather than beta activity. But it has some beta activity also. So it is a mix of best of both worlds. That is why it has become the drug of choice for sepsis. Adrenaline and dopamine, it has comparatively more beta activity compared to NORAD. So adrenaline and dopamine, it has comparatively more beta activity than NORAD, and it will have more degree of tachycardia compared to NORAD, but can also have more inotropic effect as well. But dopamine has basically gone out of favor, because studies have shown of increased rate of tachyarrhythmias with dopamine in patients with septic shock. So generally, dopamine has gone out of favor in most types of shock, basically. Then you have things like isoprenoline and dobutamine, which are predominantly going to act on beta receptors, and these are not vasopressors. They are more of the inodilator type of family. Then you have non-catecholamine vasopressors like vasopressin and angiotensin 2, which act on other receptors like V1 receptor, AT1 receptor, etc. So why combine neuroid and vasopressin? Basically, it's a good idea to have basically drugs acting on different types of receptors for a synergistic effect. So basically, how most of these will work is by arterial vasoconstriction, and they can also increase preload by venoconstriction. So they can also have some increase of preload as well. And depending on the agent you use, you can have an increase in cardiac output by some increase inotropy and chronotropy as well. So what are some of the indications that a vasopressor might be needed? So patient is having hypotension, increased heart rate, low MAP, increased capillary refill time, decreased urine output, altered mental status, and worsening of lactate. So all signs of decreased organ perfusion. These are the things that will tell you that the patient is in shock and might need IV fluids, and IV fluids don't work. Patient will need vasopressors. So, how do you titrate vasopressors? Usually, we titrate them to a map of 65. So we have this trial, the 65 trial that a map code of around 60 to 65. So it versus more higher maps in map codes in the ICU. It didn't have much of a difference on mortality, and we were basically able to wean patients off vasopressors more rapidly. And a map of around 65 will maintain perfusion to your vital structures like your brain, your kidneys, and your gut. So what about push dose pressure? Basically, when patients are there are two scenarios when you would like to use push dose pressure. One is in patients are in extremis. For example, a patient is having BP of 45 over 25, 40, 20. So you don't really have time to actually start a drip on that patient. You need to give them something very, very quickly to actually increase their blood pressure. So that is one scenario where a push dose pressure can be useful. Push pressure, the action usually does not persist more than 15 to 20 minutes. So basically a very, very short term benefit here. But when a patient is having a BP that low, patient can rapidly go into cardiac arrest, and you don't want to wait to actually start a drip for that kind of patient. So when you're similarly, if you're having expecting transient hypertension, for example, patient you are giving some sedation before intubation, that is again one classical reason for people to give push dose vasopressor. So commonly used push dose vasopressors are adrenaline and phenylephrine. So adrenaline, some usually we titrate the push dose adrenaline to a concentration of 10 mics per ml, and you give around 20 to 50 mics of that IV followed by a flush. And similarly, you can give phenylephrine as well. So the concentration will vary. So you'll have to check what concentration of phenylephrine you'll have available, and what you generally will give around 100 to 200 mics bolus followed by flush. So if neither of these are an option, another thing you can consider is vasopressin. Not very, but the thing is that if vasopressin, you cannot actually give it without a patient having a center line. So that is another question. Why can we give things like noradrenaline and adrenaline through a peripheral line, but we cannot give vasopressin through a peripheral line? Does anybody have any idea? Why can we give NORAD and ADR to peripheral lane but not vasopressin? So basically, the rationale is that NORAD, if the patient extravasates for some reason and drugs goes into the subcutaneous plane, we have antidote for NORAD and ADR. So that is phentolamine. If vasopressin extravasate, there is no antidote. That is why it is not recommended for vasopressin to be started peripherally, but you can start NORAD and ADR through peripheral line, at least initially before you transition to a center line. So that is the main thing there. So when do you actually add the second vasopressor? This is important to know because different people have different ideas. So what the trial that we have to reference is the VAS trial, which is where you had 70 patients on at least 5 mics per minute of of NORAD, basically randomized to either starting vasopressin or you just keep on increasing the dose of NORAD. So as here, the patients who were started on vasopressin earlier actually had a trend towards mortality benefit. So so if your patient is very sick and the patient is having increasing doses of noradrenaline, it is better idea to start vasopressin sooner rather than later in these kinds of patients. So what about steroids and septic shock? This is a very controversial thing, and it's difficult to give clear answers here. But I'll just give a review of what the evidence we have so far. So we have the ANAN trial in 2002, where we had a combination of hydrocortisone and fluorocortisone was given, and it reduced 28-day mortality. But this trial was criticized because a lot of the patients that received etomidate, and as you know, etomidate can produce some adrenal suppression. So there were some debate of whether that was actually confounding the results of the study. Then we had Codicus trial, which only used hydrocortisone, and this showed no mortality benefit. Although it did show that the shock improved earlier on with the hydrocortisone than without it. Hypress trial in 2016 again used hydrocortisone. This time it showed no mortality benefit or any benefit in shock reversal. A Procus trial in 2018 used a combination of hydrocortisone and fluorocortisone. This reduced 90-day mortality, the Aprocus trial. Then you have the adrenal trial, also in the same year, 2018, and they used a continuous infusion of hydrocortisone. Now, a continuous infusion of hydrocortisone is not at all physiological. Physiological, we don't have continuous secretions of cortisone. That is not how it works. And secondly, nobody uses continuous infusions of hydrocortisone. I have not seen it used in any hospital that I worked in. If you have any other experiences, please let me know. But to my knowledge, this is not something that is commonly done. But anyway, that is what they used in this study, and it showed no mortality benefit, but it might have improved some other outcomes like ICU stay or time to extubation, etc. So meta-analysis was done in 2023 in JAMA, and it compared hydrocortisone plus fluorocortisone versus hydrocortisone alone, around 90,000 patients total, and there was a more than 8% absolute risk reduction with the combination of both compared to hydrocortisone alone. So if you have fluoro available, and you can consider starting them both, or you can just add hydrocortisone as well in the patients who are not responding to usual therapies in septic shock. So now you started steroids. So you started two vasopressors, you started steroids, and the patient is still not responding. Then you can consider other things like stress cardiomyopathy. So you have something called sepsis-induced myocardial dysfunction. Other than, you can have patients who are going to cardiomyopathy as well. Basically, these kind of disorders can be unmasked by vasopressors. Basically, the heart does fine, or heart looks good initially when you evaluate, but once you start the patients on vasopressors, we see that the EF starts to decrease. So basically, with your increased SVR from vasopressors, the heart suddenly doesn't start working that way, because basically you are increasing afterload, and the heart doesn't really like that. So this can also happen, and in those kinds of cases, that is when you can consider adding something like anatrope like dobutamine or milrinone. So other things you are to consider in patients who are not responding to two pressors and steroids, always do another focus. So another focus to rule out pneumothorax, tamponade, etc. Any other obvious causes that we might have missed. Look for any underlying sources of infection. So you have any abdominal collections or some kind of infection somewhere, needs draining. Drain the infection. Without draining the infection, no antibiotics are going to go, solve the problem of a collection like that. So you have to look for that as well. So obviously you might need imaging for that. Consider things like stress cardiomyopathy that we have described, dynamic LVOT obstruction. That is a topic in itself. Basically, you consider that in patients who are, had rapidly wasn't that sick to begin with, but had rapidly escalating doses of vasopressor. They won't actually improve with your usual vasopressor. So that is something that you have to look for, and you have to actually have the skill to actually start looking for that and focus. Anaphylaxis is another thing that you should keep in mind, because patients who are intubated, can be difficult to tell if the patient develops anaphylaxis or not. So review the medication that have been given and whether the timeline fits with some kind of possible drug reaction, and you might want to consider some therapies for anaphylaxis in those cases as well. If the patient is having severe acidosis can reduce the efficacy of your catecholamine. So you might want to consider correcting that as well. And lastly, we have something called vasoplegia. So what do you mean by vasoplegia? Is a severe vasodilated state resulting resulting in persistently low systemic vascular resistance despite normal or even augmented cardiac output. So so it's basically a severe vasodilated condition. So the basic pathophysiology is either going to be due to excessive inflammation, like in sepsis, or it could be due to cirrhosis. So in cirrhosis, cirrhosis is basically a vasodilated state, and you have excess of things like nitric oxide. So these things can produce a very vasodilated state that is not responding to other therapies. So the three main conditions that this is seen is in sepsis, cirrhosis, and patients who are undergoing cardiopulmonary bypass because patient is due to exposure of blood to non-physiological surfaces. So that can also lead to a release of these mediators. So drugs that you can consider in these kind of states, especially these are things that you might consider the patient is on a third vasopressor. So these are called vasodilator scavengers. So things you can consider as either methylene blue or hydroxycobalamin. In our center, we have recently done an RCT on methylene blue for this particular indication, and the results will likely be published in a few months or the next 1 year or so. So we'll get back to you on that one later. So basically, the more evidence is for methylene blue, especially in the for the cardiothoracic surgery wala patients. So one thing for methylene blue you have to keep in mind is that the risk of hemolysis with especially in patient with the G6PD deficiency, it can also have some bad drug interaction. Risk of serotonin syndrome also is there. Another option which doesn't really have that much evidence compared to methylene blue is hydroxycobalamin. So these are at present off-label uses, but if a patient is on third vasopressor, then you have to start thinking out of the box basically to try and improve the situation. So remember that with both of these agents, you can have alterations in the normal urine color. So if you give methylene blue, the urine will turn green, and with hydroxycobalamin, it will turn dark red. So that is something to keep in mind while taking care of these patients. So just to bring it all home, be aware of the common advantages and disadvantages of the various vasopressors that we have. So having more than one push dose pressor available can be useful. So it's in every condition, ADR might not be the most appropriate thing to go for as a push dose pressor, I mean, and always have an approach on how to deal with a septic shock patient who's not improving with your usual therapies. So that is all that we have for this particular session.